Thank you. Yeah, I think you said. Sir, we are live. Go ahead.
Very good evening, doctors. Myself, Seshagiri, on behalf of Microlabs, I welcome you all for this Pride update. This is a regular update we do every month, and this time we have a topic on dapagliflozin CVD. And to discuss on this topic, we have very elite panel from different parts of the country. And to moderate the session, we have Dr. Suha Serande, who is a senior physician from the city of Pune. Can I have the slide, please? And doctor is MD and also done his diploma in diabetology. And also to just share a few details about the doctor. I'm sure many of you will be knowing doctor. Doctor is ICMR Research Fellow in Diabetes. And also he has national faculty in API, RSSDI, and Jerrycon and other national conferences. He has written chapters in Medicine Update API textbook for the last 4 years. And he has 15 international published articles in different journals. And he is also member advisory board Journal of Association of Physicians of India. And doctor also has won many awards to his credit. I request Dr. Suha Serande to take us through the session. Over to you, sir.
Thank you so much, Seshgiri, for introduction and for arranging the program. And welcome all the experts who are participating today. And I would briefly introduce our experts. May I have, yes. So, Dr. Mohanan sir is, everybody knows him, of course. He's a cardiologist from Thrissur, Kerala, director of and HOD of Westport High Tech Hospital there. He's an immediate past president of CSI. He has published largest acute coronary syndrome registry from India, Kerala ACS registry, which is very famous and well publicized. Did the largest randomized study in CV cardiovascular science from India, quality improvement study in ACS, and did the first quality improvement study in chronic heart failure in India also. So let's take this opportunity to brain pick Dr. Mohanan because he has already been in chronic heart failure in our country for quite some time. And he has received CME Excellency Award in Cardiology called as Dronacharya Award. So welcome, sir, for the discussion. Our expert from Thane, Mumbai is Dr. B.C. Kalmat. And he has an expertise in complex procedures like angioplasty, stenting, balloon valvotomy, permanent pacemakers, and other catheter-based interventions. He's involved in more than 15,000 angioplasties and 25,000 coronary angios, which is a huge figure. And he is also involved in many clinical trials conducted in Bombay Hospital involving cardiac drugs and newer intervention and devices. He has numerous publications in both Indian as well as international journals, and he has delivered many lectures in various international conferences as well. Welcome, Dr. B.C. Kalmat, sir.
Thank you, doctor. Thank you.
Our expert from Hyderabad is Dr. Sai Ravi Shankar. He's a consultant cardiologist, Aster Prime Hospitals there. He has won Best Researcher Paper Travel Award from Cardiology Society of India, Young Investigator Award, APCSI, Hyderabad, Most Promising Cardiologist in Telangana and Andhra Pradesh, Global Healthcare Excellence, Best Cardiologist in Telangana, BMJ Southeast Asia, September 16, Best Emerging Cardiologist, TOI, Vidya Ratna Award, Government of Telangana on Doctors' Day, numerous awards in the field of cardiology, 22 years of experience, special interest and expertise in complex angioplasties, post-bypass surgery, angioplasty, bifurcating, stenting, left middle coronary artery, angioplasty, chip interventions, leadless pacemaker implantation, structural heart interventional surgeries like TAVR and TMVR, and rotablators and orbital atherectomy. Welcome, Dr. Sai Ravi Shankar, to the discussion. Yeah. So, friends, let's move with the. This is going to be a fully interactive session, so don't expect to be, you can say, only listening. You can, of course, ask your questions, put them in the chat box as our discussion rolls on. And let us actually start. Actually, I will be starting on some amount of cricket background. We have been the World Cup winners very recently. So the first question, so to say, or first situation, I would say, which are the four pillars of heart failure management and what should be the approach to the management. This is, of course, beta blockers, mineralocorticoid receptor antagonist, ARNI, and sodium glucose co-transporter inhibitors, the four pillars of heart failure management. So, may I ask Dr. Mohanan, sir, to please guide us on this?
Thank
Mohan,
you,
sir?
Dr.
Yeah.
Suhas. Of course, as you rightly put it, the foundational four drugs has been providing us with a tremendous improvement in rehospitalization, in mortality reduction, and they are the time-tested drugs. ARNI, amongst the RAS blockers, we talk about ARNI more often than ACE inhibitors or ARB. So ARNI, SGLT2 inhibitors, beta blockers, and MRA are the four foundational drugs. The question has been, there is no dearth of data on the usefulness, the validity of these four foundational drugs. That's why they are called the foundational drugs. They have been proven value. The only, I mean, the confusion or the lack of definite recommendation is how are you going to sort of sequence it, which I'm sure Dr. Suhas is going to entertain us with especially with my two younger friends who are very knowledgeable friends who and they're going to tell us about the newer informations, and because this is an area where we are not very sure. We are very sure these four drugs as soon as possible in heart failure has to be started.
Right, sir. So the pertinent question here, sir, and you have used that word sequencing of the drug. So is it that the physician gives the thought to the background comorbidities and then decides which is to be started first? Maybe if he has hypertension or ischemic heart, then probably he starts with a beta blocker. He has huge diabetes, so we start with a SGLT2 inhibitor, or he has a dominant heart failure element itself with congestion and everything. So do we give a thought to ARNI or mineralocorticoid receptor antagonist or all four on board
The
as soon
problem
as
has
possible?
been, the problem has been, we as clinicians, we have a dictum that we use the initial drugs that has been found useful. The initial drug that has been found useful in heart failure has been beta blocker, MRA, ACE inhibitor, ARB, then ARNI, and finally SGLT2. So
Yes.
there was the thought process was that you go one up, one up, one up. That was the process.
Yes.
And then in 2021, the ESC guidelines said, I said, why? I said, no, that is not the way. Because all these drugs are very important and time is essential. See, we cannot just lag down. We cannot prevent somebody with heart failure from getting the benefit from these absolutely useful drugs. So people started looking at which drug gives you the best results in the shortest possible time. So that is one. Then we don't have any, as I said, McMurray started saying, McMurray is a big name in heart failure. He said that maybe we should, in every heart failure, we should start with beta blockers and SGLT2 to begin with, and then start on ARNI, and then finally on MRA. These are things based on, as you rightly said, every physician has to use their judgment, look at the background, the comorbidities, the hemodynamics, and the best possible combination should be started.
Yeah.
The era of artificial intelligence. So one of these modeling sequencing analysis has shown that amongst the four foundational drugs, if you start with an SGLT2I, that gives you a better mortality reduction. Some of these are all not randomized control trial. I should caution everybody on that. But we have some data which shows that Maybe SGLT2 because it has, unlike the ARNI or beta blocker, or we don't have any problem with congestion because it will relieve the congestion better. We don't have much confusion about the hypotension. So the only confusion is there may be some transient reduction in the GFR, which can be sort of controlled with. So this is the usual thoughts, but as you rightly said, each heart failure patient is different. You have to use your judgment. But the fundamental thing is get every 4 drugs on board as soon as possible.
And sir, another small question here, which is because when you say heart failure, then intuitively everybody will think of using a diuretic, maybe oral or maybe IV. So is there, you can say, something which is priming, which is done to the system by the diuretics, and then the 4 pillars do they act better?
Am I coloring the conversation? Am I not involving my other 2 friends? If with their permission, only
No,
I will talk. I don't
yes,
want
Dr.
to.
Mohan, I'll interrupt here. Yeah. Dr. Suhash.
Yes, sir.
Yeah, Kalmat from Mumbai. How are you?
Absolutely
Nice
fine, sir.
to
Please.
and we have a lovely allied session from Dr. Mohan. I thought I should give my input before I get cut off because my signal was a little weak. Thank you for that. No, at the outset, when the patient comes in acute decompensated phase, they will receive diuretics. There's no doubt about that. And diuretics is a cornerstone. And later, only uncompensated heart failure will receive them diuretic, even though our guidelines tell that we can cut off them once SGL2, beta blockers, mineralocorticoids, and the 4 drug comes online on board. But by and large, if the patient has wet lungs or the intake output wherein the output is higher, when the output is lesser, and they have PND, nocturnal cough, they will receive diuretic for some time, at least some time. Maybe some people get 4 weeks, 6 weeks, 8 weeks. It is it, and unfortunately, a lot of physicians still continue for many months together. That has to be cautioned. Once you have SGLT on board and ARNI, they both are excellent diuretics, especially SGL2 inhibitors.
Yes.
And also ARNI, mind you. And once they both are on, and mineralocorticoid itself is diuretic, the MRA.
Absolutely.
Yeah. So once these are the board, you should reduce the furosemide or the torsemide or the loop diuretics and cut down, because they don't have mortality benefits as much as any of these 4 drugs.
Yeah.
And having said that, the beta blockers and the SGLT shown more mortality benefits, like 38-42% benefits in the DAPA trial, in the EMPA trial, EMPA trials, and even DAPA showed a lot of 42% heart failure benefits in DAPA CKD. And no, not even the earlier trial, Diclatimi. So having said that, we will be forced to use diuretics in between when they get little uncompensated or they have failure due to not taking the water intake properly or taking some liquids more, or there is some extraneous steroids, whatever the conditions are there, then we are forced to use diuretics, but it should be short living. Otherwise, these 4 pillars, and maybe the 5th pillar is the ivabradine and the IV iron therapy, and sometimes the Versugard. These are other 3 pillars which are not yet time tested, but the time tested are 4, and the IV iron therapy and ivabradine with the tachycardia. One other suggestion I wanted to add to your beautiful discussion is that you will have to individualize a patient. A diabetic patient who is a tachycardic and waterlogged, you have to start him on beta blockers, SGLT inhibitors first, and then followed by ARNI and MRAs. And a young gentleman who has dilated cardiomyopathy and tachycardic, first beta blocker, then followed by he's reluctant. He's not even diabetic for another 20 years, but you'll have to add his DAPA little later after beta blockers and ARNI. And a CKD patient, first DAPA and then of course beta blockers and ARNI if required, if possible, because looking at their GFR. Thank you so much.
Right. So some kind of monitoring, and the least probably contraindicated generally, and the least monitoring required drug is of course the SGLT2 inhibitor, because most of the others will require some kind of monitoring as all of us appreciate. So let's move to the next situation. And I would request Dr. Sai Ravi Shankar to please guide us. Sir, where do the guidelines, especially the American Heart Association and Heart Failure Society of America, where do they place DAPA in heart failure? All varieties, the heart failure with preserved ejection fraction, mid-reduced, as well as reduced ejection fraction. Sai Shankar, please, sir.
Ravi, you are muted. You are muted, Ravi.
Yes. Good evening, sir. Good evening, Mohanel sir, and good evening, Kalmat sir. Thank you for giving this opportunity. Before that, the first discussion, only few words only. They rightly said, Mohanel sir, every heart failure is a totally, we have to see, is a different individuals. All are none. So second point is, as early as possible, we have to give all four at early. Third, Kalmat sir has told, we have to see that whether the heart failure is in heart failure with reduced ejection fraction or preserved ejection fraction. So that depend upon also we have to which drug we have to give. I hope we are talking about heart failure with reduced ejection fraction. Fourth point, I just want to, yes, one is important factor in heart failure is most of the time cardiorenal. So the creatinine part is the most important and hyperkalemia is the most important. If the creatinine is high and potassium levels are high, yes, the RNA is the fourth step. And first we have to give the SGLT2, beta blocker, MRA, and fourth is RNA. Again, if we are giving the RNA, depending upon the EGFR, then we have to wait and watch. We have to repeat the RFT level. Now, coming to your point, DAPA, where we are in DAPA is class 1A indication in all the guidelines like ACC or EHA guideline. Whether it is a only drug which I can tell you, whether it is a heart failure with the preserved ejection fraction or reduced ejection fraction or mid-range ejection fraction or with recovered ejection fraction. Now we have 4 types of heart failure, not 3 types.
Yes, sir.
Even all this DAPA has shown in very good drug to decrease the morbidity and mortality also. So all the 4 drugs, the ACC, AHA guideline and European guidelines and in the Indian Cardiology Society of India guidelines also, DAPA is a class 1A indication where it has shown very tremendous increase in the very good to reduce the mortality, not only mortality, MACE, reduces the hospitalization, heart failure with hospitalization. So DAPA considered to be class 1A indication in any type of heart failure.
Sir, now before we deep dive into the heart failure and renal or cardiac and diabetic issues, for a practicing physician, when the patient complains of whatever New York Heart Association grade, then he starts searching for the heart failure element. So, is it possible that we do it something which is preemptory? Do we feel that maybe after if your diabetic is ridden with comorbids like hypertension or maybe some compromised kidney function, maybe EGFR is something like 70, not grossly reduced, but still reduced. Maybe he has albuminuria. ECG is normal, and he doesn't have any kind of complaint of NYHA scale breathlessness. So do we do a 6-minute walk test? Do we do a biomarker? Do we do a echocardiogram preemptively? What's your advice?
Absolutely. The patient, when he comes with some pedal edema or a breathlessness, we have to find out, we have to do certain cardiac tests. For example, ECG, echocardiography, NT-proBNP will give you a better picture. Other than that, we have to do the RBS test, creatinine test, and potassium RFT test so that we can come to know this patient is in heart failure or not, because NT-proBNP is a very good marker. And in the echocardiography also, the strain pattern, whatever the longitudinal strain pattern also gives a very good important feature for the heart failure. Whether it's a heart failure with preserved ejection fraction or reduced ejection fraction, we'll come to know by echocardiography. the EF is more than 50 or less than 50, or less than 40 also we can come to know. So the battery of tests are minimal to diagnose a patient with a heart failure. But anyway, we have to go with the clinical symptom. As a physician, we have to see the clinical symptoms of the heart failure, the basic heart failure symptoms. If the symptoms and signs are positive, then we can go ahead with some of the lab parameter and the ECG echo parameter. Then after the treatment, we can, yes, the patient is improving, how much we want to upgrade or titrate the higher dose of beta blocker. We want to increase the RNA. First started with 50 milligram BD, then we can increase to 100 milligram BD. As per the trial also, RNA is given up to 200 milligram, 200 BD also. So to titrate that patient is improving or not prognostically, 6-minute walk test is a good, very basic thing we can do in the heart failure clinics.
Right, sir. So
I
that's
just
something
wanted
which
to,
is,
I just
yeah,
wanted to,
sure.
Suhasana, since we are talking about now the risk stratification and identifying heart failure, just like we identify ASCVD risk score, we don't have any definite risk scoring system for heart failure. But then we are going to see those in high risk individual. What is this particular individual's risk scoring, develop chances of development? Mind you, John Gleason has said all of us who is above 55, Ravi is accepted, above 55 is going to die of heart failure unless we die of an acute MI or any other malignancy or something else. So heart failure is going to be possibly for physicians the #1 cardiovascular disease in the coming years. We have been concentrating on ASCVD more often. Of course, ASCVD and heart failure go almost together. So is there any way, as Ravi said, you look at the age and the other risk factors, and then the biomarkers definitely going to help. Unfortunately, they're expensive, but then people have found out that BNP, in one of those BNPs, troponin, and with these multiple modalities, we possibly may be able to identify them. Unfortunately, now we don't have any drugs which prevent heart failure. The antihypertensives are possibly the only one which has shown to prevent heart failure. SGLT2 inhibitors over the very many trials has shown to prevent heart failure. I'm talking about prevention. I'm not talking about treatment. And in prevention of heart failure, we don't have much choices. We don't have much because RNA has not been tried much in prevention of heart failure. But if you look at the Declare and all the other SGLT2 trial, EMPA, GAPA, they have been shown that is one of the promising molecules. And of course, any antihypertensive will do better in preventing the heart failures.
Yeah.
Thank you.
Right.
Sir,
One more
yes, sir.
one word only.
Yeah.
Rightly said, Dr. Mohan sir. I just want to add that there are, if you ask me, the stages of heart failure, stage A is at-risk heart failure. That means people who are at risk for the heart failure, but do not yet have symptoms or structural functional. So even if stage A also at risk also, though they don't have any structural or functional heart disease, that means risk factor for the people of the stage like hypertension, coronary vascular disease, diabetes, obesity, these are all the at risk patient. So this type of patient, we need a large randomized trial in a stage A. Yes, of course, stage B is a pre-heart failure, people with current symptoms of heart failure, but I am talking about stage A heart failure. Yes, there is a need for these drugs like SGLT or MRA or RNA. Whether stage A heart failure, we need a large randomized trial.
Sir, incidentally, when I was going through the literature, I came across one magic score, which is a meta-analysis global group in chronic heart failure scale, which takes into account the age, sex, systolic blood pressure, diabetic status, COPD, use of beta blocker, etc., etc. And that gives you around two figures, which is 1 year and 3-year mortality attributable to heart failure.
Yeah.
But they have categorically said that this is not yet validated externally for HFrEF patients. So I believe which Sai Shankar sir is saying that the pre-heart failure, that's or maybe stage A, probably that is one where we may think of using these kinds of scores, may be attributable or applicable more to the Indian population and take the matter further. So let's move to the next situation, which is what are our learnings from the Declare TIMI trial. So I will again ask Mohan sir about guidance here. Sir, what are our key learnings from Declare TIMI trial, especially in type 2 diabetes individual with previous myocardial infarction? So secondary prevention.
Basically, the gliflozin trial has been a revelation for us. When the EMPA came, when EMPA data was presented, we all of us know about the amount of surprises element. If here is one anti-diabetic drug which gives you a mortality reduction, which gives you reduction in hospitalization, and that was the beginning. And over the years, people have used it in diabetics, in non-diabetes, in a person with atherosclerotic valvular disease, person with risk factors. Declare was a little different from because it was with partly an intermediate risk. I will say it like that. It is not like the previous other trials, and it showed that definitely in every subsets of Ravi was mentioning about the various phenotypes across the ejection fraction, the heart failure based on phenotypes, the HFrEF, the HFpEF, the mildly reduced heart failure, and the I will use the term improved heart failure rather than the recovered heart failure, because the recovered heart failure was causing some confusion. So the improved heart failure. So all across it, SGLT2's benefit has been shown in diabetics and non-diabetics. Of course, there was some confusion that is there any difference between those who had an MI and developed heart failure and those who had now only multiple risk factors. But then, mind you, all across the group, it's only a gradation which is there. Now, those who had an MI has substantial benefits. Those who has multiple risk factors, that is what we have seen in all across the very many trials that we have seen the 4 molecules. So that's what we should be advocating our friends, our clinician friends. SGLT2 is a wonderful molecule in preventing and treating heart failure, and one can use it all across the spectrum of very many phenotypes of heart failure, whether he has an atherosclerotic vascular disease or not, whether he has diabetes or not. That'll be my suggestion.
Yeah, absolutely. So that was a very pertinent guidance you have given us. And I would ask now again, Dr. Talmat sir.
Yeah.
Yeah, sir, you are on board. Very good. So what are the learnings from DAPA HF trial, sir? Especially HFrEF and all-cause mortality point of view.
No, just Dr. Mohan talked very lucidly and very beautifully. But at the outset, I wanted to dissect the 2 trials of EMPA-REG and the Declare, and before coming to DAPA HF, is that
yes, sir.
The EMPA-REG had lot of patients who had to have a secondary prevention. In means, what I mean is they had very sick patients who had like already an MI, angioplasty, bypass surgery, and all these patients were very high, maybe about more than, in fact, they were predominantly there. Whereas Declare, I think we had 50-50, like patients who had like more of a primary prevention. What do you mean? They did not have even before MI, before an angioplasty, before a bypass. So despite that, DAPA did very, very, very well on heart failure admissions and heart failure mortality. Vis-a-vis, the CV mortality and MI reduction was seen more with EMPA. But whatever reason, I don't know. I'm going to ask the elite, Dr. Mohan, what is the reason? Because there are no, of course, we cannot compare the both the molecules head on, because there's no head on trials. We cannot. But if you have a comparison like that, the primary prevention of heart failure and heart failure admissions, what I mean, heart failure admissions and the mortality for heart failure was seen more with slightly more. It's a relative thing, more with DAPA, and even DAPA was more useful in the HEP-REF as well as HEP-PEF. Both the mortality was reduced. No other molecule came near SGLT inhibitors in reduction of the so-called symptoms, the KOLs, that is quality of life, and to some extent the mortality in HFpEF patients, because we don't have many drugs for HFpEF patients, unfortunately, except the SGLT inhibitors and sometimes ARNI. So having said that, the DAPA heart failure was showed that the DAPA was a powerful molecule, whether it was HFrEF or HFpEF, and the mortal reduction was more than 38, 36, 40% reduction compared to the other. So I don't think we can compare like that. But if you want me to dissect, if the patient who had already had a heart failure with a very low EF and already had an MI and angioplasty bypass surgery, I would probably err on EMPA. But if a patient has a more of a primary prevention in a lot of risk factors and CKD, yes or no, CKD is funny because the guidelines tell us that the EMPA can go to 20 GFR, 20 ml, whereas DAPA of 30, the guidelines, but it is again debatable. They are gone as low as 20 and 30, and we can probably go more or less on DAPA. So the beauty of the trial was that it was a phenomenally important molecule for heart failure admission reduction and mortality reduction in heart failure patients, whereas MI reduction was small and overall CV reduction, CV mortality was less compared to EMPA. So now the debate would be, again, we are not going to talk about CANA, which is now fallen off for many reasons. So having these two trials, these two molecules have to be compared in that sense. Thank you, Dr. Shishir.
Yeah. Sir, to that effect, I again had one interesting observation published in Frontiers of Pharmacology last year. It had compared DAPA CKD versus EMPA kidney. And they had looked at a parameter which is called as cost needed to treat rather than numbers needed to treat. And that was derived at by annualized number needed to treat multiplied by annualized cost of therapy for both the drugs. So it was interestingly observed that among the CKD patients, EMPA was better value for money for renal and CV endpoints vis-a-vis DAPA, and these were diabetic patients. And when you looked at non-diabetic patients, DAPA fared better for especially cardiovascular disease prevention, and EMPA proved to be good for CKD progression halting. So very interesting observations if we really want to pit one against the other, so to say.
Correct.
No, there was there was a meta-analysis of about 700,000 patients. Some 28,000 on EMPA and some another 15,000 on DAPA. So as you rightly said, a patient receiving EMPA were less likely to experience the composite of all-cause mortality or hospitalization. But then these are all now analysis. One thing is for certain. EMPA, the gliflozins are, as a group, are possibly the best because they fundamentally correct a derangement in the cellular homeostasis that drives the progression to heart failure. And the best drugs for prevention of heart failure. No questions about that. But there was some comment about the mortality reduction. When you come to talk about mortality reduction amongst the 4 foundational drugs, gliflozins are not the best. That we have to realize. We have better drugs for mortality reduction in beta blockers, MRI, even ARNI. So that is some distinction we have to make. But when it comes to prevention of heart failure, symptomatic improvement, quality improvement, your 6-minute walk, then that is different. So that is something which people have to realize.
Yes, sir. So coming to now, Sai Ravishankar, sir,
Yes.
Sir, the softer version of the issue now, learnings from the deliver trial, wherein the patients were mildly reduced or preserved ejection fraction phenotype. So what were the learnings from that?
So, just want to tell the declare Timmy also. The
Yes, sir.
DAPA has shown good to the diabetes and for the non-diabetes also, whether it's a previous MI or a acute maybe. So what we are doing also, the role of ARNI also we are comparing. Of course, DAPA is having some and rightly told also explained by Dr. Kamath also, EMPA has got also an important role that depend upon the EGFR. So ARNI doesn't show that much of benefit in acute MI heart failure, wherever DAPA is showing very good result. Either SGLT, I can tell SGLT is showing good result to decrease the MACE compared to ARNI. ARNI compare with one of the trial, ARNI compared with the AC inhibitor. Even both are looks same, or there is no mortality benefit in acute MI heart failure. That is about the acute MI heart failure. Now coming to the DELIVER trial. The DELIVER trial, the effect of DAPA in total heart failure events in patient with heart failure with mildly reduced or preserved ejection. That is the only thing in DELIVER trial. All the trials which we have discussed is heart failure with reduced ejection fraction. So in this DELIVER trial, actually, the thing is the DAPA reduces the rate of total heart failure events. That means first and subsequent heart failure hospitalization and urgent heart failure hospitalization visits also. The cardiovascular deaths, regardless the patient characteristic, including the EF also it is. So the very important is heart failure with either mid-range heart failure or preserved ejection fraction in the DELIVER trial clearly proves that it reduces the mortality, MACE, primary and secondary prevent. And most important is the NT-pro BNP also levels also, which is reduced with the DELIVER trial, and the kidney functions also has improved prior to hospitalization. So overall compare, the DELIVER trial shows very clearly heart failure with either preserved ejection fraction. DAPA has got a very important role.
Yes, sir. Now the other trial, which is a small trial, really speaking, but interesting trial, and that was quite invasive, which looked at the pulmonary capillary wedge pressure, so to say. That was called as Cameo DAPA trial. So what's the role of DAPA on the hemodynamics with reference to plasma volume and body weight as per the Cameo DAPA trial? I believe all of you are very interventional cardiologists, so you will certainly be fond of looking at pulmonary capillary wedge pressures and the effects thereby at the baseline and at the end of 24 weeks.
I will ask Ravi to talk about more on
Yeah,
this. But then
I
basically,
can tell
the gold
also.
standard, the gold
Yeah,
standard
please.
heart failure with preserved ejection fraction is a hemodynamic study. That's the gold standard. But then we hardly do it. We hardly
Yes,
do
sir.
it because we
Yes, sir.
have other means of doing it. But as you rightly said, we don't know the mechanistics of SGLT2 benefits, phenomenal benefits in all across the heart failure segment. And one of the things that has been found with the gliflozins in obesity, in HFpEF, preserved ejection fraction, is the fact that it tremendously reduces, apart from reducing the intracellular and the interstitial volumes. That's why you have tremendous advantage of starting SGLT2 in the first 48 hours and people responding excellently well. So apart from that, there is a, I mean, that has been, we knew it, but now we have proved from this particular study you quoted that there is a reduction in the pulmonary PCWP with the gliflozins, and that could be one of the very many mechanisms. We honestly don't really know. There are 15 or 16 or 20 mechanistic ways by which SGLT2 helps us. Ravi.
Yeah, absolutely. Chemio trial is absolutely important, though it is a very less number they have used. The basic thing is we have to understand that DAPA is nothing but one of the diuretics. So because of this diuretic effect, the PCWP has reduced. That is a basic thing. And they have in this Cameo trial also they have compared with PCW with at rest and during exercise.
Sir.
So both this and 24 weeks they have taken, and both at rest and at the after exercise also, the pulmonary capillary wedge pressure has reduced. So basically, this is because of the plasma volume has reduced and body weight also reduced. So this is very good. Even that also proves that DAPA has got a role in heart failure with preserved ejection fraction.
Yes, sir. Sir, quickly alluding to Professor Milton Parker, who illustriously keeps writing on various aspects of heart failure, analytically as well as RCT-wise. So he says that in type 2 diabetes, hyperinsulinemia is the chief insulting agent for heart failure, increased heart failure risk. He even alludes to insulin itself, the secretagogues as well as pioglitazone, which increases insulin signaling, who can increase the risk of heart failure. Or pioglitazone, of course, we know. But those like SGLT2 inhibitors or metformin, who don't actually increase the insulin signaling, act in a different way, they certainly reduce the risk of heart failure. And molecular level, also, Professor Parker has guided us on a lot of things. For example, in a nutrient surplus situation, he says that we have protein kinase C and mTOR, which increase the glucose and lipid stores in the cardiac myocytes and raises the oxidant strain. Mitochondrial bioenergetics also changes, and SGLT2 inhibitors, they do what is called as fasting mimicry. So the opposite sensors, which is SIRT1, which is anti-inflammatory, and the AMPK, which is the energy sensor, that is improved. There is a phenomenon called as autophagy, which is housekeeping or replenishing of the organelles. So the ER stress, endoplasmic reticulum stress, is reduced. Lysosome-induced replenishment of the dead or let's say old organelles, including mitochondrium, that is also facilitated. And that's why the cardiac bioenergetic changes. That's what Professor Milton Parker always have been teaching. So that's the reason why beyond glycemia, we get a lot of effects. Other important thing at the kidney level, he says that SGLT2 overexpression is obviously one way by which it is useful, but sodium hydrogen exporter, 3 in the kidney, 1 in the heart, that also is affected by SGLT2 action. And that's why the sodium exchanges certainly are better. And that's the reason probably why we look at dapagliflozin as a useful drug across the phenotypes of heart failure. So these are the different ways with which some explanations we are getting. Of course, not full, but certainly some explanations we are getting. So let's move to the next situation, and which is the DAPA comparing with ARNI now. So Ravi sir, you can always take this up. So DAPA compared to ARNI in individuals with mildly reduced or preserved ejection fraction. Hair splitting, so to say.
Right. So there is no doubt that heart failure with reduced ejection fraction, both are having good role, DAPA and ARNI. And when I compared with the DAPA versus ARNI in preserved ejection fraction, there are few things I just want to. First thing, there are few trials like delivery trial, Paraglide trial, Paragon HF trial. All these things very clearly proves that even if you the annualized number needed to treat and the hospitalization, heart failure hospitalization, DAPA provides a better than ARNI. And because the ARNI is little bit even costlier, and it is to be given BD dose, the lowest price in the India also, it is almost around 25 rupees. So per day cost is 50 rupees. Wherever DAPA 10 milligram is very cheap now, less than 10 rupees also it is available. In that way, in Indian scenario, I can tell that it is better monetary value than the ARNI in preventing overall composite outcome of the total heart failure. And total heart failure, not only heart failure hospitalization and CVT MACE rate also has reduced. So compared to all the three trials which I have told, pardon?
Yes. No, no. Sorry. Yeah, I just
Yeah, please.
wanted to add one more point, Sai, here. Very nicely you put it. Only in reduced ejection fraction, I would say ARNI may fare better in preventing so many readmissions and quality of life unimaginable. I have few hundreds of patients who used to get admitted every 2 months for heart failure. Once ARNI has come on board, whenever the EF is less than 40%, 35%, 20%, so they do much. I mean, what
now we
that is
have now, for example, we have data which shows that the NNT, if you compare the NNT, these are all retrospective, otherwise analysis. And there are, you can always pick fault within these. Now you can say that NNT with DAPA was 30, while NNT with ARNI was 44, but then these are all in HFpEF. We don't know for sure. What we know for sure is in HFpEF, class 1 is only Flowsin, and ARNI is till now a class 2A or class 2B. Americans believe class 2A, yes, he believes, the Europeans believe class 2A. So in HFrEF, there is no question that the drug which makes the difference, we have seen it in real world, is ARNI.
I do agree.
It gives the patient so much relief from the symptoms. So, but unfortunately now every drug has to be on board, and we are not here to split it between the two, and which is better and which is not.
Correct. That's right. Thank you.
Yeah. So the comparison, and I would just quote one healthcare management cost analysis here. It's of course from US. So the annualized cost, as Ravi sir said, they are far less with DAPA, $1,48,547, and the ARNI, it is $2,45,346. So certainly cost-wise, ARNI is costlier, and probably the monitoring involved with ARNI also will be something which will add to the cost. Less monitoring required with DAPA, hardly a dose. DAPA, everybody will be on 10 milligram. So there is nothing like a dose titration or whatever, which is a case with ARNI. So from that point of view, the convenience also is better with dapagliflozin. Now the next question.
One point,
yes,
just
sir.
want to.
Yes,
Yeah,
sir.
DAPA is now all the companies, most of the company, they are coming with the DAPA with some combination. Bisoprolol with DAPA also coming. So if you compare the monetary value, it is going down also, it will be. So it will be DAPA combinations are coming on the pipeline, and within couple of months, you will get into the DGCI permission they want. Already everything is done. So that will give you more or less cost to the Indian patients.
Absolutely, but that's very good because
for your information, our group, our research group, I'm part of it, is trying to get a polypill, heart failure polypill, and we are going to about to begin that trial in Sri Lanka, maybe in another 3 or 4 months. We don't have a regulatory approval in India. So we have taken that data with all the 4 foundational drugs to in one pill. So it will definitely come.
Absolutely, absolutely, sir. So the next situation will be how, at what level of left ventricular ejection fraction should we be starting dapagliflozin in the patients?
We have no problems because all across the ejection fractions, if it is heart failure, proven by the symptoms, heart failure is a clinical diagnosis. Everybody, we have been taught like that. So if you have an evidence from the biomarkers and echo findings and all across the heart failure, we can use the gliflozin without any problem, without bothering the dose. So that is that.
Yeah, thank you, sir. So you have simplified the matter for the
there was some confusion in the earlier the Emperor preserved trial, which showed that if the ejection fraction is more than 65, 57, 58, 60, then the effects may be attenuated. But then the declare disproved that. So we don't need to worry about the hypercontractile heart failure with preserved ejection fraction. All across the very many phenotypes of ejection fraction, please use gliflozins, SGLT2 inhibitor.
Yes, yes, sir. So you have really simplified the matter for the physicians, no question about it. And Kalmat sir, you are on board, sir?
Yeah, I can
sir.
join. Yeah.
So in diabetic hypertensives who are on diuretics and beta blockers, would it be prudent to add dapagliflozin? And at that time, is it advisable to wean off diuretics? In fact, you had already alluded to that weaning of diuretics in your previous discussion.
Nick, no, in diabetic hypertension, there's no question that we have to add DAPA or SGLT as early as possible. There's no doubt about that. And having said, I was earlier also telling that once the patients will come to a situation where their fluid status is very well managed, and then that time we can take off the diuretic. That's where it's important to know that, because we just don't want to continue the diuretic for a long time. It unnecessarily causes electrolyte imbalance and a lot of other metabolic derangements. So having said that, in diabetic hypertensive, definitely ARB, if not ARNI, then ARNI is become moved up class 1, going to class 2 and class 1 now. If there is HEPREF, in replacing the AC inhibitors and ARBs, and of course, DAPA or one SGLT inhibitor has to be added in these diabetes, because only not anti-diabetic, anti-heart failure, even either incipient or manifest heart failure, whatever it is, DAPA will be, as Dr. Mohan beautifully told, that you don't have to look at the EF for these patients at all. Yeah, but especially when the diabetic patients, by and large, they start reducing their strain images, the LVA size goes up, and they have the difficult 6-minute test, and all that will add, and that's why we have to add as early as possible to DAPA.
Absolutely.
Thank you.
Absolutely. Sir, the next question, Sai sir, I would answer actually half of the question because it's related to diabetes. So we will technically, in DAPA use in heart failure, we will technically not think of DAPA if the patient has type 1 diabetes, maybe a history of ketoacidosis, or maybe something which is a Fournier's gangrene in a very obese or maybe patients who are not able to keep their personal hygiene proper, etc. But otherwise, do you see that there are any contraindications to using dapagliflozin?
No, already my co-panelist Dr. Mohan sir has told we can use in all type of heart failure range, like starting from HFrEF to HFpEF. And as you have told, type 1 diabetes or ketoacidosis, only contraindication in my view is patient is having acute UTI infection. In that case, at least wait for some time. Once the infection, urinary tract infection has reduced, in that, other than that, I don't see any relevant thing to not to start DAPA.
Absolutely. In fact, from the point of view of routine practice, genitourinary mycotic infections are more of a risk rather than urinary tract infections. And actually, the lot of pamphlets now, they are proactive. They technically advise about the personal hygiene, plenty of water intake, etc. But they tell the patient that you use the antifungal drugs if you happen to have those symptoms. There was no publication on this, especially from a respectable body. But the United Kingdom Kidney Society, they have published their view on this October 23, and they say that for the looking at the large number of benefits which the gliflozin group of drugs offer, just to you can say shy away from their use in a patient who has urinary infection or genitourinary mycotic infection, that may not be the real story. So they say that you aggressively try to treat that infection. Maybe you can withhold the dapagliflozin or any gliflozin for some time. If at all, change the gliflozin if really required. But try to give it to as many of the patient as possible. Don't get frightened because of that genitourinary mycotic infection. And as diabetologists, we know that if we combine gliflozin with a gliptin, then the relative risk of infection certainly comes down. That's another point. So generally,
just one point,
yes,
I just wanted to talk about a trial published last month in June called it the Defender randomized clinical trial, where dapagliflozin were used for critically ill patient with acute organ dysfunction. See, this was an area where people were worried. We were worried about that, whether we can even try. You remember
sir.
the COVID situation, we were, even other any we tried to restrict, we withdraw the drug. Now we have data which shows that the addition of dapagliflozin, the standard of care for critically ill patient and acute organ dysfunction, definitely did not improve the clinical outcome. However, the confidence interval were wider and the benefits are definitely marginal. But then don't you worry. We
Yes,
don't
sir.
need to be very
Yes,
much
sir. That's the
worried
point.
about all the
Yeah.
hemodynamic consequences of it.
Yeah, because otherwise what happens, sir? 4-5 pus cells in urine and we are compelled to, or maybe we are a bit jittery whether to stop dapagliflozin. That's very important. So that's a very nice guidance you have given, sir. And last situation, anybody, sir, can take. This is the role of dapagliflozin 5 milligram in
Yes.
diabetic hypertensive patients. This is your
Right.
personal experience, sir.
Yes,
Fully personal experience.
I can tell you the practical problem. Once we start, any cardiologist will start at any cost DAPA to either of these heart failure with preserved ejection fraction. Most of the time, preserved ejection fraction patients are very healthy. They don't see any symptom because reduced ejection fraction, of course. Once you start DAPA and the patient will go to the physician level, they do the routine RBS and urine sugar, and of course they will tell that you are not a diabetic. They will stop it. So DAPA has proved that even though it is a diabetic and non-diabetic also patient, DAPA has got a role. Number one, once they see even the 10 milligram for reduced ejection fraction, this is a practical problem. Once some of the doctors see that urine sugar level are 4 plus, they reduce it. They don't want to hide it because already a cardiologist has given 10 milligram. I'm reducing the dose, or patient insist themselves that my sugar levels are very, very, so they reduce it. So I think DAPA 5 milligram has got no role in my view. And in fact, maybe sometimes it is a just like atropine half ampoule is not, it is even detrimental to the patient. So in my role, I never gave 5 milligram, and none of the studies also prove 5 milligram is better.
Absolutely, sir.
I mean,
Absolutely.
Ravi, I just wanted to interject and say that we have more and more information about it. As you rightly said, cardiologists never have used 5 milligram. Diabetologists, as a HbA1c reduction with 5 milligram is proven with something marginal reduction. We have again another data called a DAPR trial, which was
Yes.
published a few months ago, which
Yes.
has used 5 milligram dapagliflozin. So it's again, I will just give you a gist of it. So although dapagliflozin at a dose of 5 milligram did not reduce urinary albumin excretion in patients with heart failure and type 2 diabetes, the DAPR guys found out dapagliflozin decreased cardiovascular events and suppressed left ventricular remodeling. But then again, I should caution you, this is a 300 patient data. But then let us wait for some more time. Let us wait and see that whether there is any chance for the diabetologists are using for HbA1c reduction. We have all data with 10 milligram. We will be very keen to know. Even though I do agree, cost-wise, 5 and 10 doesn't differ. But if I want to use it in a smaller dose, why not? I am welcome to that particular idea. I'm not averse to that idea. That's all I'm saying.
Yeah, sir, this is a Japanese trial which you absolutely
Absolutely.
perfectly pointed out, because of that has used, DAPR has used 5 milligram dose. The patients at baseline were normoalbuminuric and their HbA1c was, average was 6.9. So technically, from this point of view, they were actually low risk patients. But still, you had that observation of reduction of cardiovascular events and LV remodeling, which is which we should certainly take note of. No RCT has used 5 milligram, very obviously.
Absolutely.
So
Absolutely. And we don't want to touch it. We don't want to touch any 5 milligram for the time being.
Yes, sir. Absolutely right. Absolutely right. So I believe that we are closing on our
Yes.
last whistle for the
9:45.
program. And I would certainly say that all our experts, Dr. Romohanan sir, Dr. Kalmat sir, and Dr. Sai Ravi Shankar sir, they have given us excellent nuggets of knowledge, their personal views and their personal experiences also on various shades of using dapagliflozin, especially in heart failure, but in some other situations also. Though we didn't really deep dive into the renal aspects of the story, but still, whenever we say heart failure, compromised EGFR certainly comes on board, and they have given their views on that as well. So, my friends, I'm sure that we will take this is very important information, very practical information to our practicing table, and maybe offer benefits to the chosen reliable patients of heart failure, diabetes, and the other shades or other phenotypes as we have listened to right now. Thank you so much, all experts. And if anybody of you wants to make any comment, please, sir.
No, thank you.
Thank you. Good night. Thank you.
Thank you, sir.
Thank
I
you,
would
sir.
like to express my deep sense of gratitude to Dr. Mohanan sir, Dr. Ravi Shankar sir, and also Dr. Suhas Aranda sir. And also, I would like to thank all the participants. We had about 300 doctors joining in from different parts of the country. So thank you all, and also the field staff of Microlabs for making a success of this program. Thanks once again. Good night.
Sagar, we can go offline.